12-year-old male, right hemiparesis since birth, and refractory epilepsy since 3.5 years of age, most of the times during sleep. Screams followed by jerking of the right side of the body and blinking of both eyes. The seizure lasts around 10 to 15 minutes. Several episodes of status epilepticus requiring hospitalization, severe developmental regression, and difficulty in learning, attending special school. Neuroexamination, right hemiparesis, non-functional right hand, limping gait, and preserved speech. This is his MRI. We can see here there is a cyst over the left frontal region. And also we can see that there is no cortex of insula over here. So if you open the cyst, the medial wall of the cyst is actually the lentiform nucleus and also the caudate nucleus. And also here we have a ischemic area, probably from the ischemia that occurred in the early phase of his life. So in conclusion, this patient presents a ischemia probably during his early life, the ischemia of the territory of the middle cerebral artery on the left side. Here we have the sagittal view and coronal view. Sagittal view, you can see the extensive ischemic area over the frontal and the parietal operculum and the dilation of the lateral ventricle. This is the coronal cut showing that cyst, showing the cyst and the medial wall of the cyst. There is no insula. It's already the basal ganglia, lentiform nucleus, and also the caudate nucleus. This is a coronal cut of the most posterior region showing the dilated atrium. This is a choroidal plexus and ischemia, early life ischemia over this region and a tremendous dilation of the atrium. So this patient underwent left peri-insular hemispherotomy. This is the position of the patient and also the skin incision. This is the exposure after the dural opening. This is the posterior temporal region. This is the left temporal lobe. This is posterior part of the Sylvian fissure here. This is the location of the postcentral supramarginal gyrus, and that cyst that we see is more in front. So let's go to the video. Here is the cyst over the frontal lobe. So the first step of the surgery is the splitting of the Sylvian fissure. We open the Sylvian fissure. In children, this is the MCA. In children, the arachnoid membrane is much thicker than in adult. And then continue to use sharp dissections and mostly using scissors or knife and exposing the branches of MCA over the insula. Actually, in this case, there's no insula. So continue to open the Sylvian fissure. This is that the frontal cyst that we see on angiogram, not angiogram, on MRI. Continue to now coagulate a bridging vein. Now the M2 branches, this is M2 branches over the genu of the MCA. M2 branches over the basal ganglia because there's no cortex of insula here. Now I'm removing the lateral wall of the frontal cyst. We know that the medial wall of the cyst is actually the caudate nucleus and also the lentiform nucleus. There's nothing to be removed here. And now, there's no cortex of insula either. What I did is just to coagulate some small branches going to this region. And now I am approaching the inferior limiting sulcus of insula because I want to approach the temporal horn and perform the selective amygdalohypocampectomy as part of the surgical steps of the hemispherotomy. Now the temporal horn has been accessed, reached, and then I am enlarging the exposure of the ventricular cavity. This is the inferior choroidal point, the beginning of the choroidal plexus. So the amygdala is located in front, ahead of the inferior choroidal point. Now I'm doing the subepio dissection, keeping the pia intact to protect the carotid artery, anterior choroidal artery. Now I'm trying to isolate the amygdala, which is located within the boundaries of the uncus. Now this is the head of hippocampus. I'm removing by suction. And here is the amygdala. It's located ahead of the inferior choroidal point. And the landmark for you to resect the upper limit of the amygdala is the optic tract. Now I'm removing. This is amygdala. We can see through the transparency. This is PCA, P2A segment. Removing the amygdala means removal of the uncus. So now I have removed the amygdala. And now I'm working lateral to the hippocampus, which is lateral disconnection through the collateral eminence. Now I'm back to the medial side. This is hippocampus, body of hippocampus. Now I want to see more. I want to expose more. So I have to open more of the inferior limiting sulcus of insula. Now I have exposed, better exposure now. And here's the hippocampus again. Here's PCA. This is head of hippocampus up to here, and then it begins the choroidal fissure. I'm splitting the choroidal fissure by opening the tinea fornicis. This is a lateral geniculate body over here of the thalamus. I split this one, this lateral geniculate body. I split as far back as possible of the choroidal fissure. And then here we can see the arachnoid membrane, and this is the hippocampal sulcus carrying the hippocampal arteries of Uchimura and also the transverse hippocampal veins. Now I'm working once again on the lateral side of hippocampus and then medial side again. This is hippocampus sulcus with hippocampal arteries and veins. You have to cut, coagulate and cut. Otherwise, you cannot remove the hippocampus. Now I'm aspirating and sucking the perihippocampal gyrus, subepial dissection, leaving the pia arachnoid intact to protect the midbrain. Now I'm lifting up the hippocampus. So you work on both sides, lateral, medial, and then you cut at the transition between the body and the tail of the hippocampus. So the selective amygdalohypocampectomy has been performed. Now this is glomus, the choroidal plexus of the atrium. Now I have to expose better the cavity of the atrium. So I have to remove the posterior part of the superior temporal gyrus and also the supramarginal gyrus. I want to expose well the medial wall of the atrium. You have to preserve the arteries and most of the veins because you want to, even disconnected, the sick brain will occupy the space. If you don't preserve the vessels, soon the brain that you left in place will be absorbed, so will disappear if you don't preserve those arteries and veins. Now, I am removing the lateral wall of the atrium, and then I want to proceed to expose the entire lateral ventricle from laterally to medial. So now I'm removing the seat. This is the upper part of the atrium, entering already to the body of lateral ventricle. So I'm removing what the remain of the opercular, frontal and parietal opercular, to expose the enlarged ventricle, lateral ventricle. So this is what I'm doing. This is supposed to be the superior limiting sulcus of insula, but due to ischemia, there is no such sulcus. Now I'm trying to remove what is the supposed to be the operculum, the remaining of the operculum, the parietal operculum. So I'm coagulating on the surface, cutting on the surface, and then I go to this is ventricular cavity, corpus callosum. This is the roof of the body of the lateral ventricle. So I'm following what I did on the surface, connecting the surface to the ventricular cavity to remove this part of the remaining part of the frontal and parietal operculum. So I follow the cavity of the ventricle and then go superficial again, coagulate, and then go down to the ventricular surface, ventricular cavity. So carefully look and carefully open in the ventricle in the beveled dissection. Beveled because this way the light of the microscope can enter better, get into the cavity. So now I'm removing and continue to follow the ventricular cavity, but also I am connecting on the surface to remove the remaining part of the operculum. So you go on the surface and then you go deep to follow the ventricle, and then finally you remove what the remaining of the operculum, frontal and parietal operculum. This is caudate nucleus, this is corpus callosum, this is ventricle. So I have to continue this way because now we're at the body, genu, and then soon rostrum of the corpus callosum. So I'm working on the frontal horn. Now the operculum, frontal parietal operculum has been removed. So we got this view. Now we're back to the temporal side, temporal lobe, and this is the medial wall of atrium with the medial atrial veins here. So what I do is we have to disconnect the medial wall of the atrium as well. But we have to have a landmark to follow. So I use the edge of the tentorium because at this point tentorium will turn to become falx. So if I follow the edge of the falcotentorial edge, it would be the very good landmarks because there's nothing so important lateral to the this edge, but medial to this falcotentorial edge, you can see here I'm following the edge. Medial to it, there's going to be important structures, brainstem, thalamus. So I am disconnecting the medial wall of the atrium, and in the depth I follow the edge of the falx now. You see here. And by following the falx, I am disconnecting the at least region, the forceps major. Now I'm doing the intraventricular callosotomy. Once I am working inside the ventricle, and I will find the intercerebral artery, the pericallosal arteries You see here? But the pericallosal arteries are located in the inner hemispheric fissure. So I'm going from the inside of the ventricle to reach the inner hemispheric fissure. See here? Pericallosal arteries over the body of the lateral ventricle. I have crossed the corpus callosum. This is the intraventricular callosotomy. So now what I'm doing is just follow the pericallosal artery, the anterior cerebral artery, all the way from the body, the genu, and the rostrum of the corpus callosum. And then finally, I have to disconnect the frontal basal region. So this way, this brain has been completely disconnected from the central core. The cortex has been disconnected from the central core. And this is the final aspect of the surgery. So you remove the frontal and the parietal operculum, and then you do the selective amygdalohypocampectomy, and then you expose very well the entire lateral ventricle from the back to the front, and then you disconnect the medial wall of the atrium by following the edge of the tentorium and then the edge of the falx, and then you perform the intraventricular callosotomy by disconnecting the corpus callosum from the inside the ventricle to reach the inner hemispheric fissure, having anterior cerebral arteries as landmarks to follow the ACA all the way through the body, the genu, and rostrum of the corpus callosum. And the final step is to disconnect the frontal basal area of the frontal lobe. And here we have the post-op MRI showing the removal of the left mesotemporal region. You can see the temporal lobe has collapsed a little bit. You can see the lines of the disconnection. You see here, you'll see here. So we are actually isolating the central core from the rest of the brain, sick brain. And also we are, because of callosotomy, we are isolating the sick brain from the healthy brain. So once again, you see the lines of the disconnection, disconnecting the corpus callosum here, and also isolating the central core. Once again, the line of disconnection. Coronal cuts of the post-op MRI showing basically the lines of disconnection, removal of mesotemporal lobe structures, and the intraventricular callosotomy. Here you can see. He became free of seizures after the surgery performed in 2017 without additional neurological deficit and has shown great improvement in his learning and development processes ever since. Now he's attending a regular school. For those who are interested in the hemispherotomy, I published in 2004 this paper, Anatomical Landmarks for Hemispherotomy and Their Clinical Application.